Welcome to the AA Podcast, our little corner of the web where we are not afraid to discuss tough questions like,
when did nutrition, health, movement, and stress management become alternative medicine?
Where we embrace challenges in all aspects of life to become healthier and stronger versions of ourselves.
And where food and movement are the best kinds of medicine, and cooking meals at home is a revolutionary act.
Hello, and welcome to another episode of the AA Podcast. This is Ashley Olson.
And I'm Andrea Crane.
We are going to do part 2 of our series that we started last week on primary care, what that looks like, what an office visit actually consists of. So I'm excited to get into like the kind of the nitty-gritty of what visits are. But before we do that, we are going to share our weekly Bible verse, and mine is coming from Romans 8:26, and it says, "Likewise, the Spirit helps us in our weakness, for we do not know what to pray for as we ought, but the Spirit himself intercedes for us when groanings too deep for words."
I love that one. Okay, so mine is Luke 4:40. Now, when the sun was setting, and this verse is about the only and greatest physician. Now, when the sun was setting, all they that had any sick with various diseases brought them unto him, and he laid his hands on every one of them and healed them. And this is talking about Jesus, and none of us in primary care are Jesus. So
No, ma'am.
Jesus healed everything. We sadly are unable to work with that kind of efficiency, but we do the best we can.
That's awesome. Well, Andrea, last time we dove deep into why visits are so short in the patient realm, not so much in the physician realm, and what we as patients can be looking for and understanding when it comes to looking for a primary care physician. The differences between MD and DO and NP and PA and all the things. And what really goes into a single quote unquote simple office visit and why that they aren't so simple. So I think, for me as a patient, it just helped me understand that the amount of charting and amount of detail that has to go into these visits on the back end really requires so much more upfront sharing when it comes to setting up these visits. When you call the office to set up these visits, like, hey, the more detail, how embarrassed I feel when I'm making them, is so much better, because then that doctor or the physician can go into this feeling way more prepared and understanding what they're getting themselves into before opening that door. So now let's go into types of primary care visits and what definitions, I guess, would be these visits.
Yeah, so there are so every primary care practice has several types of visits, and sometimes well, all the time these visits are they're quantified by insurance codes, but we also, even if you're not functioning within an insurance-based model, you will still have these specific types of visits. And I just think it's super helpful when you as a patient call up, you can inquire as to, oh, okay, will this be considered my annual visit? Will this be considered my established care visit? Like, is this an acute visit? How much time have I been allotted for this visit? Because that way, like, for instance, if you call up and you're like, so I need to check in about my blood pressure. Well, the front office might say, because they make the determination, you don't talk to the provider to set up your visits, you talk to the front office. They may make the determination that, oh, this is going to be a 15-minute visit. Well, Maybe you want to talk about, listen, my pressure has been 200 over 110 for the last 2 weeks, and we probably need to talk to you a little more about that. And maybe you haven't been on blood pressure medication for 6 months, and maybe you've got a whole host of other symptoms that you need to discuss. And so it's really helpful to know, like, okay, what kind of visit am I being slated for here? So I just want to describe all of these different kinds of visits that we see, and so that you have more knowledge when it comes to scheduling these.
Love it.
All right, so the first one, and this is literally the first visit that you have with a provider. This is called an established care visit, and I think nowhere is there a more frustrating visit for patients than the established care, or a more poorly understood. And I will be the first to admit that, in the medical community, we do not provide good education on what these visits are supposed to be.
Hmm.
So, an established care, literally, it is a get to know you visit. Very often, now I will say, for myself, I work in a functional medicine setting, and so ours, we function a little differently, because we do deeper dives. We tend to spend a little more time with patients. Um, but that said, you will not usually get a physical, any kind of physical exam in an established care visit.
Yep.
Okay. And so this, we may have time for like a quick concern of yours, but if you have something wrong and you are finding a new doctor, and you call up the clinic and say, hey, I'm new, I want to start seeing so and so, they'll schedule you a visit. But you know what, that visit, the primary reason that you're there is not to address that complaint. And if the word complaint offends you, please go listen to the last episode. We talked about some of the terminology we use. But yeah, if that's
Basically, they're very rude. Just
concern,
kidding.
yes, I should say concern. I should say concern, and get into that habit. But yeah, if you've got big deep concerns that need addressed, then you probably need to schedule both an established care visit and then also a follow-up visit.
Which is so like that, just that little piece of information just blows my mind.
Yeah,
I don't
and
know if
people
it
don't.
does y'all's because you're just like, well, this is common knowledge, Ashley. You should know this. But I don't think it is.
No, I
Like
don't think it is either.
when I realized that an established care visit just is a get to know you
Mhm.
session,
Mhm.
that just kind of eased my anxiety of like,
Mm.
oh, I've got to get all these things done
Mm. Yeah.
in a very short amount of time. And also, I think it's very important too. So like when I did my established care visit last year with my primary care, I was actually surprised how much time she did take with me.
Mm.
I think it was a 45-minute
Mm.
allotment. I don't think we ended up taking that much time, but I didn't feel rushed. I didn't
Mhm.
feel like I was just checking off boxes in her little tablet, you know?
Mhm.
It was a true sit down. I want to get to know you. I want to know how you want to be
Mhm.
treated. And so it was kind of just refreshing.
Yeah. Yeah, and that's what it's supposed to be. So we schedule 45-minute visits for established cares. And now, not all of those 45 minutes are provider time. It's like the MA. And again, go back to the last episode and we'll tell you exactly where all of that time goes. But I do get to spend a lot of time with my patients, during these established cares, and it's fantastic. So during that time, it's, yes, it's absolutely a meet and greet, but it's also like, we get your vital signs. I get that baseline level of vital information, right? I know what your height is, what your weight is, what your BMI is. I know what your blood pressure is. I know what your oxygen level is. I know what your temp is. I can watch you walk in the room. We gather so much information that just comes through our eyeballs, as we're looking at you. Um, And so then I will also be sitting there and kind of interviewing you because I want very specific information with regards to, so like in a functional setting, I ask questions about your birth. I want to know if you were a vaginal or a C-section birth. I want to know if you were breastfed or bottle fed, because that sets up your gut for, everything that comes later on.
Yes.
And so, yeah, there's a lot of questions that I have the privilege to ask that a lot of times in primary care providers just don't have the time. So I feel very privileged to be able to spend that time. But I'm going to ask about your medical history. I'm going to ask about your health history. I'm going to ask about your family health history. Did you have first degree relatives with X, Y, or Z conditions, and when were they diagnosed? I'm going to ask about allergies, and that includes food allergies, drug allergies, environmental allergies, latex allergies. I'm going to ask about any sensitivities that you have to foods. Maybe it's not a true allergy. I'm also going to ask about what medications are you currently taking, and also what supplements are you on. So it helps to have that list. And then I'm also going to talk to you about like your exercise and energy levels, and what foods are you eating, and what's your alcohol consumption. Do you use any illicit drugs? Do you use any medications for other than their intended purposes? There's a lot of really in-depth questions that we ask and that we need to know. And yeah, it's a lot of information. And then finally, I want to know what your health goals are. In fact, on our questionnaires at our practice, we ask, what are your top 3 health concerns? Like, I want to know, what can I help you work on? What is the biggest thing on your mind? Now, and we touched on this a little bit in the last episode too, but I want to know, like, if your top 3 health goals, if I look at you and I see something glaring, like, oh my gosh, we've got to address this, this could be life altering, and it's not in your top 3, then we'll have a discussion about why I'm concerned, why I think we might want to address this first. But all of this is done in a very collaborative environment, so I want your input. I will give you my input. It's very much a back and forth conversation. And then, so that will last, gosh, I would say I probably get to have 30 full minutes with my patients during these. And again, that other time is chewed up elsewhere. But what I've,
Because remember, the
Mhm.
moment you check in, the time clock
Right,
starts.
exactly, exactly. And so, now, also, if you fill out that intake paperwork, now I know that's a huge complaint that people have. Like, I filled out all this information, then they come in and they ask me the exact same questions. It's like they didn't even read it. Yes, I understand that that happens, and hopefully, if you listen to the first episode, you can see how that could happen. Um, there are certainly people who have been doing this for years and years and years, and they are almost on their way out because they just can't take it anymore. It's a high burnout profession, and I get that. And hopefully, it's a little more understandable how that happens. Not that it should happen, because it shouldn't, but it does, unfortunately. So, but what I get to do, if you fill out that paperwork, and you answer all of the questions and answer it thoroughly and honestly, then the night before your visit, I will get to go through all of that information. And then I can come in and be really efficient with our time, and I can go more into depth. And maybe if you have that one concern, then I can actually get to it in your established care. Um, but yeah, it's likely, if you've got a pretty complex medical history, and a lot of people do these days, then it's very likely that in order to get all of that information and have a really thorough picture of who you are, that's going to take our visit time. And so, what I'll need you to do is, yes, but I've got these 3 things and I want to talk about these 3 things. Yes, what I really want you to do is make another follow-up visit, and then we will give those the time that they deserve, and we'll dive into those. So that's what the established care looks like. It's literally so that you can establish yourself as my patient. I have your information now. I am now your primary care provider. We have a legal relationship that has been set up. And yeah, and now you can bring your concerns to me.
All right. So, would it be good for somebody when they're setting up a primary care and establishing care with somebody? Could they, in that same setup conversation, which a lot of like when I set mine up, I actually did it online,
Mhm.
but I could immediately go back in and just do a regular follow up visit.
Mhm.
Like you could just go ahead and stack those.
Yeah.
So you're not having to wait months
Oh
necessarily.
no.
You could do like a few days
Yeah.
or maybe even potentially the same day.
Probably not.
Okay.
Because, there may be some blood work that can get
True.
ordered at an established. Like, for instance, if you haven't
Mhm.
had any annual baseline blood work, and you came to see me now, our visits work a little different in functional medicine, but
Mhm.
pretty much a standard practice. Like, if I was seeing you for an established and you hadn't had any care in the last 5 years, then I'm probably going to order like just an annual panel, and then we'll talk about those results at your follow-up.
Can we visit that for a second?
Mhm,
So when I ordered my panel,
mhm,
it was kind of a basic all like I got everything. I got hormones, thyroid, vitamin
mm,
levels, cortisol, like the whole 9 yards.
mhm,
It was insanely expensive.
mhm. Yeah.
Now, I know I can go and order my
Mhm.
own through Life Extensions.
Yep.
Talk to me about the difference there. What kind of kickback, if you will, does the doctor receive?
Mm,
I
okay.
all Is there also a difference whether the doctor is ordering it, whether
Uh-huh.
the PA or MA
Uh-huh.
is ordering it? Like
Yeah.
what is all that?
Yeah, that's a great question. So, yes, you are correct. There are lots of lab services now, and I am in full support of this. I really am. I think, it's your blood. You should be able to know what's in it.
Yes.
Um, so I'm very supportive of this. Now, you mentioned something. You said, what does the uh, provider's office get when we order it versus you order it? And let me just tell you the difference. So, one, financially, we get nothing.
Wow.
There's no, there's nothing. Like, there isn't any money that exchange hands when I put the order in, and or I, in collaboration with my medical assistant, we put your orders in, and yeah, there's no money at all. It's just part of your visit. It's part of my time that it takes to order those. um, and then further, I don't get anything for the interpretation of those labs either. So again, that's all part of the time that it takes, you know to take care of you. So when your provider orders the lab versus you ordering the lab, so I order labs that I think are important based on the information that you've given me. Now, if I order it, I own it. If I order 15 labs for you, I own those results. I have to comment on those results. I am responsible for the findings on those results. And so if you're in practice, and okay, here's why we don't do, it's called a pan scan. Here's why we don't put all of our patients through a giant MRI or a CT once a year. Well, first of all, the radiation on the CT would be terrible. But why don't we put people through these machines, right? We would find cancers, we would find all kinds of things. Why don't we just do this? Because you know what? There are just legion incidental findings. It's literally called an incidental finding. Sometimes you'll have an incidental finding that'll be like, holy cow, we need to treat this. Like, oh, I'm so glad we found this. But 99.9% of the time, an incidental finding that's off means nothing. And so then you're down a rabbit hole. So for instance, if my patient, there are tons and tons of inflammatory markers in the body, for instance, that that can be like way high because you worked out super hard the day before, or because you have cancer, or because, right? And so if I order this humongous panel of labs for which you have no symptoms, then I will get so many incidental findings that I will then have to track down. It's unnecessary care. It's completely unnecessary care.
So talk to me about like, because I think I could have ordered my same blood work
Hmm.
for a fraction of the cost.
Yes. Yes. So,
Now, I also have a high deductible plan.
yes. Okay.
So
Hmm.
that also, so I am out cash, but I could have still, I think, used my high deductible account to pay for the like life extension.
Yeah,
So,
I believe you can use an HSA account. Now, you would need to check with an HSA to see if, do I need a doctor's order for these labs in order for you to pay for it?
true.
And it may not be. You may be able to just, go and order your stuff. Now, you can certainly go and pay cash for whatever you want, but
Right.
a lot of these things are really expensive. So,
So why was there such a drastic price?
yeah. So, now, if you are talking about paying cash uh versus if I ordered it for you, then it would have been more expensive.
Right.
Okay, and that's through another lab? Is that through another lab that you're talking about?
Yeah, I don't know what lab. Well, I went to LabCorp
Okay.
to get
Uh-huh.
them drawn.
Okay. So there's a difference between a cash price. So and this is so convoluted. I'm glad you're asking this question, and I hope that I can give an answer that provides some information, but it's a very convoluted subject. So when patients pay cash for things, often there are contracted rates that these labs have. And so if you go in, even with my order for you, you can say, hey, don't bill insurance. I want your cash price. Tell me what your cash price is on this.
Oh,
Yeah.
interesting. Okay.
And see what that is. Now, if you have insurance and I order labs for you, you go to the lab with your lab order in hand and you say, here, this is my lab order, bill my insurance, and they do it. If your insurance says we're not paying for this, we're not paying for this, we're not paying for this, then that lab will do something called a balance bill. And they will say, your insurance paid for $30 out of this $960 lab panel. You owe us $930. But
Thanks so much.
yeah, but yeah, exactly. Check or charge. So that would have been like maybe $470 if you had paid cash, right? And they had never billed insurance.
Ah,
So that's the difference. They try to bill insurance this huge amount, and insurance says, nope, we're only paying you this amount,
but then that's still your bill.
but that's still your bill. Yes.
Yeah. Okay.
So that's where some of that
So
comes
that's a
from.
good question to when you guys are
Yep.
getting your panels done, ask whether what's the cash price?
What's the cash price? But you also want to call. So if you're getting a functional medicine panel, so for instance, some of the things that I want to know about my patients yearly, I want to know their vitamin D level.
Yep.
I want to know a hormone panel. Like
Yep.
for my females, I want to know estrogen, progesterone, testosterone. But you know what? I want to know those on my males too.
Yes.
And so I don't order luteinizing hormone or follicle stimulating hormone unless I need to, because those are typically not covered.
Okay.
I can generally get a hormone panel covered, provided I have a reason to order it.
Okay.
So if you're telling me that you have, really heavy periods, really terrible cramping, I've got some facial hair growth, I've got, weight loss problems, I've got this or that or the other, I can't sleep, then sometimes those are codes that I can put in that they'll say, okay, I guess this is necessary, we'll pay for it.
Okay.
And I work with patients on that. Now, if they don't pay for it, then you're in that position where they'll balance bill you. So
Mhm.
we always encourage patients, get on the phone with your insurance company and ask them, my provider ordered these labs. Will you cover it?
Oh, yeah. So kind of basically doing some due diligence, if you will.
Absolutely. Yes, because we don't know. I mean,
Mhm.
there are, my goodness, Blue Cross alone has how many policies that we take, and they all have different requirements, different things they'll cover, and different contracts.
Yep.
And so we can't possibly know with all the insurance companies. We don't know what your insurance will cover and what they won't. Sometimes we have some knowledge just based on experience,
Mhm.
but that knowledge is subject to change too. So we'll be helpful wherever we can, but ultimately the relationship is between you and your insurance provider. And so get on the phone with them. I know it's a pain to call. I know
Yeah.
that it is, but you will get to somebody,
Mhm.
and you will get an answer.
Yeah. And yeah, so if I would have done that, then I would have been like, okay, potentially I would have just paid the cash
Hmm.
price, or I would have just gone out and done it on my own
Yes.
through life extensions.
Yes, yes, because there are, so even with the labs, like LabCorp you mentioned.
Mhm.
So LabCorp will have a contract price with Life Extension
Yeah.
for their panels. And then they will also have contracted prices with each of the insurance companies. And then they will have a cash price that is completely different from the other two.
Yeah.
So, yeah, I know it's complex, but hopefully this is
But
good
just knowing
information.
like, oh, it's not again, it's not a one size fits all. It's
Right.
not a like I have to
Hmm.
order these through my doctor.
Yeah.
Here are the questions I should be
Hmm.
asking. Like
Right.
this is just not common
Yeah.
knowledge.
And now let me throw in another something here, okay? So, based on our last episode that we did about all of the time constraints and the responsibilities put on primary care, if you go out and you order, you know, 3,700 labs on your own, and you then bring them to your doctor's office and you have a stack of paperwork and you say, here, these are all the lab results that I want you to look through. No, you didn't order them. No, you didn't necessarily go through my symptom list and think that I needed them. I just ordered everything I possibly could, and now I want you to look through it and tell me if there's anything wrong. See, that doesn't that that is not going to happen,
Okay.
because that is not how medicine is done. Otherwise, that would completely bankrupt the system. Like,
Mhm.
if every provider just said, yes, let's get 3,700 labs on every single patient. Let's get a yearly MRI. Let's get yearly ultrasound scans of your abdomen. Let's get, like, if we did medicine that way, it would bankrupt the system overnight. So we have to be, we have to do we have to be responsible with people's resources. And when I say bankrupt the system, like, if I practiced that way and insurance would cover it, insurance would be bankrupt. And then
Mhm.
you couldn't afford any of the premiums. Like, premiums would be $3,000 a month to pay for all of that. So all of these things have to be balanced. So that's why, whether we're talking a nursing model or a medical model, if you have questions about that, listen to the last episode. When we're talking nursing or medical, we are all taught to elicit information in the same way. We all follow subjective, objective assessment and plan. That's how our notes are set up. That's how our interviews are set up. And it's a very methodical approach to getting to what is the matter with the patient in front of me.
Okay.
Okay. And so, based on that interview, then we order tests. Then we perform a physical. I am not going to put hands on you unless it is warranted by the interview that I do with you, right? Like, I'm not going to physically place hands on you without you saying it hurts here. right? Because that's basically that's assault. I mean,
Okay.
I don't, you have bodily autonomy, you have bodily agency, and nobody has the right to put hands on you unless there's something wrong. um, at your annual, there are certain things that we do as part of an annual physical. I will check your eyes, I will press on your belly, I will check your spine, I will check your reflexes, like those things, but that's understood as part of an annual visit.
Yeah.
So yeah, just so that you know, there's a very methodical approach, and that's why we don't just like shotgun order labs on everyone. And that's also why your provider will be kind of like, I don't, yeah, I'm not going to look through all of those, I don't have the time.
Hmm.
And there's probably incidental findings in here that once I see them, I have to run them down. Like I then have to order more, and I then have to, yeah, so that's why it's not that they're not interested in you.
Right.
It's just that they can't afford to do that on everyone. There just isn't time.
Okay. All right. Okay, so we've established the established care
Yes.
visit. We've established that most likely it probably would be due diligence if you do have concerns to go ahead and do a follow-up visit
Yes.
at the same time,
Sure.
schedule it at the same time as the established care visit. And then we have our annual visit, wellness check, if
Mhm.
you will. And talk to me about um talk to me about like what that visit entails.
Mhm.
Talk to me also about like, does this need to be applied to everyone? Like,
Mhm.
does everybody need an annual visit, a
Mhm.
wellness check? Do we, what are some things that maybe in your functional practice
Mhm.
you might be a little different than a more
Conventional sense.
conventional
Yeah.
setting?
Okay, so yes, the annual visit, and this is the source of a lot of contention among patients, and I completely understand that. In fact, just in the interest of transparency, I don't do annual visits.
Neither
Um,
me
yeah,
either.
I,
Yeah.
I get that. I do totally get that, but I also I see the need for them. When I'm practicing by clinical guidelines, national guidelines from national agencies that look at this stuff. I don't always agree with their guidelines, but yes, it is recommended that you get an annual visit. Now, if there is something going on,
Mhm.
and we touched on this again in the last one, a lot of things will produce some pretty standard blood aberrations. So we'll see some aberrant lab values, and I can look at this value or that value and say, oh, you are a pre-diabetic, and I know you don't feel like a pre-diabetic. I know you don't maybe feel like your cholesterol is this, that, or the other, but here is your lab value. I know you don't feel like your vitamin D is tanked, but here's your lab value. And so these are all part of like an annual lab that I would get. We've also got a spate of thyroid disease in this country, right?
Yep.
And so a lot of times, you know, uh, people will
I mean, we're
complain.
seeing a influx of just autoimmune in general.
Yeah. And so, people will have concerns about fatigue, and thyroid's always on the list.
Yep.
And so I want to know where your thyroid is annually.
Yeah.
I run deeper labs than just a TSH.
Which I think that'll be a whole nother
Yes.
episode too that we want to do because yeah.
Yeah, we can talk about the difference between like what a functional provider would order annually, and then what a conventional provider would order annually. Um,
Exactly.
yeah, so so anyway, I guess for the medically complex patient, annuals are very important.
Yeah.
For the functionally minded patient, they're also really important. So if you are the picture of health, if you have no complaints or concerns, then do your thing.
Yeah. Sometimes ignorance is bliss.
Yes, I know. And these annual visits. So let's talk about what is included in an annual visit. What does this even
Yes.
mean?
Yes.
Because here's here's what happens sometimes. People will like save things up for their annual
Yes.
visit. I see this so much and it's like, "Oh my gosh, I literally have a checklist of things that I have to get through for your annual visit because this is a defined term. An annual visit isn't just some nebulous thing. It is a defined term where there are very specific metrics that I have to get through. Um, and so it's anywhere between 20 and like 45 minutes. It includes a full physical. Like I do a head to toe physical on you. I will go into what that does not include anymore based on clinical guidelines. Um, but I also need to ask about all kinds of screenings based on your age, mammograms or ultrasound or whatever you prefer, colonoscopies, Pap smears, eye exams, hearing exams, lung cancer screenings, skin checks, mole checks, those kinds of things. Like all of those are included in this annual exam, and I need to collect that information because if you say, "Oh yeah, I got this weird thing. Can you take a look at it on my skin?" Yes, that can be part of your annual for sure. And I'm going to look at it. I'm going to say, well, like I can biopsy that and send it off. Or if it's on your face, you don't want me cutting on your face. So I'll send you to dermatology. Um, but all of those screening type things can happen. I can give you a referral to order a mammogram. I can refer you for a colonoscopy. So all of those things, again, that's part of what we do in the background is sending all those referrals. We communicate with other physician offices. Um, so here are the screenings that are no longer recommended by clinical guidelines. So some of you women out there, you probably remember getting annual physicals with a bimanual exam, and some of you are probably still getting those because there are older providers that are still doing it that way. But this is an ovary check. So during your gynecological exam, there will be a hand on your abdomen as well as a hand checking your cervix, and they'll try to feel your ovary in between those two hands. That has really fallen out of favor. It's a bit of an uncomfortable exam for women, and we just don't have a good we don't have a good feel for
Literally.
yeah, I mean, literally, we cannot feel ovaries that way anymore. People used to be really, really slender, and so you can feel an ovary. But now we don't have those types of bodies anymore, and you can't feel ovarian changes through adiposity or through the thicker tissue. We're even more muscular than we used to be, and so that's difficult too, even if you've got a slender but muscular patient. So anyway, those kinds of things we don't do by manuals anymore. We also don't do clinical breast exams anymore. So when you don't get that yearly your provider may have done a clinical breast exam where the provider actually felt for lumps or fibrous tissue or whatever. It's not effective. It isn't effective. And once you find something, again, it could be fibrous tissue. A lot of women have really ropey kinds of tissue in their breasts. Caffeine consumption causes fibrotic breast tissue. And so when you're a provider and you're feeling something, it's not my breast. I don't know what this normally feels like. And so I've got to send you for an ultrasound or for a mammogram to figure out what this is.
So it's one of those incidentals again.
Yeah, that's exactly right. And so they don't recommend that we do clinical breast exams anymore. Now, we still encourage women to do monthly self breast exams because you know what it feels like. You own you own this body. You live in it. You know what
Mhm.
it normally feels like and you know if there's changes.
Yeah.
Now, certainly if you come into my office and say for a follow-up visit, then I will absolutely feel it and see what I think, whether we need follow up or is this what is this?
Right.
So Anyway, we also don't do prostate exams anymore. And there is a very simple reason, what, two simple reasons for that. One, if you got a female provider, generally our hands are not big enough to be able to feel a prostate. I mean, that is just the long and short of it. So that's funny. Um, but also, like, we don't do that every single day. We're not urology, right? That's their specialty. And so being able to distinguish um, prosthetic tissue that may be boggy or tumorous or whatever, it's it's very difficult to distinguish the difference when you're trying to perform a prostate exam. And so, yeah, we do PSA screens, and we send you in if you're symptomatic. Again, it goes back to symptoms, right? So, yeah, that's something that we don't do anymore either. Okay, so now I will also, on an annual visit, again, we'll order those annual labs.
Now,
Um,
is that a conventional and
mhm,
okay?
yeah, a conventional practice, um, and this applies to functional or conventional practices. They can order your labs ahead of time so that you can review those labs maybe in your annual visit.
Okay.
Sometimes they'll order them at the time of your annual visit, and you don't get a follow up visit about those labs. They only call you if they're abnormal.
Yeah, like when I got mine at my
Hmm.
last year, she just wrote notes in my account,
Yeah.
and it was like a message that
Yes.
popped up for me.
Well, yeah, and that's the thing. Like, there's probably a lot of abnormal values.
Yes.
But as a provider, you look and you say, yeah, that could be dehydration. This could be due to, I know that this patient works out hard, and that could be due to an acute inflammatory response. Not concerned about that, not concerned about that. But when you as a patient look at those, you see these are abnormals, and you're like, oh, there's a lot of red on this lab report. Well, it may or may not be important. Yeah.
Yeah. And this is a whole nother episode too, but like when we are looking at
Mm.
labs, me and Andrea are wanting to look at optimal and
Mhm.
not just like you're living.
Right. You,
Like you're still alive, you're
that's
fine.
right. You're on the right side of the sod.
Yes.
So
Yeah.
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 And yeah, functional ranges are something very different.
Yes.
Okay, so now you want to talk about the next type of visit. So we talked about annuals. Now, the last thing I want to say about annuals is you can see there's a lot to get to
Yeah.
in that annual
Mhm.
visit. So when patients are like, "Oh, I saved up these 5 things to talk to my provider about during my annual," no, 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 no. Make a follow up so that we can really address that stuff.
Yes. Yes.
Okay, so now let's talk about the follow up visit.
Okay.
So a follow up visit is basically like this catch all for everything else.
Okay.
So, if you have a specific problem, if you have a concern about symptoms that you're having, that the provider knows that you are hypertensive, let's say. I keep picking on hypertension because there's so many hypertensive people. But yeah, your blood pressure doesn't seem to be responding to your medication. Your blood glucose is high. You are getting headaches and you're not sure why. Yeah, make a follow-up visit. And when you call, follow-ups can be anywhere from, well, gosh, in a conventional sense, follow-ups can be anywhere from like 10-minute appointments to,
And is that from walking in the door to
yes,
yeah.
they will schedule 5 people an hour. Hmm. Yeah. And think about all the charting activities that have to occur. Think about all the referrals, all the lab orders, all the that have to occur for all those people potentially.
That's
It's
crazy.
crazy. Yeah.
That's crazy.
Excuse me. Okay, so a follow-up visit, you need to say, like, hey, how much time are we slating for this follow-up visit? Because they'll tell you. They'll say, "Well, I've got a 30-minute appointment here for this follow-up," or "I've got a 20-minute appointment." And at that
Or 10.
time, or a 10, and at that time, you can say, "Hey, you know what? This may be a little more complex than that. I've got a lot of things to talk about with the provider. So could you schedule me for a little longer visit?" And they may say, "Yes, we can, but I'm gonna need to have you come on a different day." And hang on, sorry, I really wish that I had a cough button here.
Oh, you're
So
fine.
I'm real sorry about that cough.
I can edit that out.
Oh, okay. Hmm. Um, so yeah, so be flexible, but they'll find you a longer appointment if that's what you need.
Okay.
And really, that's what you need to do in order to get the care that you need, and to make sure that you and the provider has enough time scheduled for you, because there is nothing that stinks more than for me to like get up because we're out of time and I've addressed the thing that they came in for, but then they, as I stand up, "Oh, I've got like three more questions here," and then I have to say, "Oh shoot, let's have you make a follow up, because this, we were only scheduled for a little bit of time here today. I want to get to that, but I just can't."
Okay.
Yeah.
That's good information.
Yeah.
Um, Now, say you did ask them for a longer time slot, would that potentially be billed twice to
No.
insurance? Okay.
No, and that's where the codes come in. So remember I was telling you about like the specific codes that some of those codes indicate that this provider spent more time.
Okay.
Okay, so I can do like a non-complicated code. If you come in for a sore throat and you're in and out, then I bill for a non-complicated
Okay.
visit. But
Okay.
if I bill for a complicated visit, then I've got tons of charting to do. I've got tons of codes. I've got, a lot of work to do.
All right. All right. So basically, it comes down to honestly asking more questions when you're setting up these
Yeah,
visits.
and that's totally fine. Like people don't mind.
Well, I think it's so intimidating for one to even set up an appointment.
Yes.
People are already like hypertension
Right. Yeah.
on this subject of like,
Mhm.
oh my gosh, I guess I need to establish a PCP. I really
Mhm.
don't want to. I really dread going to the doctor's office. There's already that level.
Right.
And then you get on the phone and you're just like, oh, I made the appointment. It's almost a sense of relief. But
Right.
then you're like, oh, shoot, I should have been asking all these questions. And it's just basically comes down to education
Mhm.
on, hey, this is not your world. Like, this is not
Right.
your world. Like, this is not common knowledge for
Mhm.
most individuals. And so,
Mhm.
this is what we want to be able to provide you, me and Andrea, like this knowledge of, like, hey, we understand as I'm saying we, but
Mhm.
Andrea's office where she works, they understand that when somebody calls in, this is not their knowledge
Mhm.
base. And so, they want questions. They
Yeah.
want to be able to provide you with
Yeah.
a experience that feels like you're being heard and that you're being seen.
Exactly.
And so it's okay as patients calling in to ask more questions. And
Mhm.
honestly, I wouldn't have known that
Yep.
had I not talked to you.
Yeah, and I don't think as a community, and again, like this just speaks to so many of the problems that we face in our Western way of life. It's just so cutthroat all the time. Like we're just working ourselves to death.
Yeah.
We're stressed out to the max, and nowhere is this seen probably more egregiously than in primary care. Primary care is one of the highest burnout areas of medicine. We literally see everyone. We get paid the lowest out of any of the medical. Out of any medical specialties that you can go into, we get paid the least. And I do newborn visits, and I can see all the way up to, a 98-year-old patient. You see everyone for everything. and you are expected to have a baseline level of knowledge about all of these things. So, I'm your first stop for everything. And I try to handle everything that I possibly can because it costs time, it costs money, it costs aggravation, and it costs stress for to send patients to specialists.
Mhm.
Sometimes I have to do it because
Yeah.
I don't have the expertise to handle what they're coming in with, and they could be better served by a specialist like gastroenterology or urology or neurology or hematology, right? If they're better served by somebody in a specialty office, then I'm going to send them. But if I can handle it myself, I will. And so, yeah, it's just a super high burnout field. So if you can advocate for yourself as a patient, know that we want to work with you. We want to help you. And the more you know, I don't want my patients walking out feeling like, well, that was a disappointment. I don't feel like she heard me at all. I don't feel like she wanted to listen to me at all. I had six more things I wanted to talk to her about. And I hear you. Make that expectation known so that we can say, hey, let's schedule another couple appointments for you so that we can get these things addressed, you know?
All right. Yeah. So bottom line,
Should we
ask more.
talk about
Oh,
acutes?
oh
Should,
yeah. Sorry.
yeah, there is one more type of visit.
All right. All right.
And this is, coming from emergency. This is, I love to do acute visits. This is where we, we'll sew up a finger, we will, um oh gosh, we'll look at sore throats. We'll do a urine dip. If you think you've got something that's happening right now, you've got symptoms like an illness, like cough and cold season. If your allergies are driving you crazy and you just need something now, then we'll schedule you for an acute visit. And those are the shortest visits of all. This is not a follow up. This is just a quick in and out. It's almost like you go to one of those urgent care places. Think about those kinds of complaints. And very often, if your primary care office is closed and you have an acute complaint, then you would go to an urgent care. Or if your primary care office is, slam packed for the day and you can't get in, then you would go to an urgent care. But we can often fit some acutes into our day.
I was just about to ask, is there kind of a buffer in your daily okay. It's just
Nope.
like wherever we can slide you
Yep.
in. That
That's
person didn't take as long, so we're
Yeah.
sliding you in.
Well, and so let me speak to that a little bit from a functional standpoint. So again, we see fewer patients but more complex patients, and I can absolutely have 14 patients in a day that are very complex. Now, what that means is that our reimbursements, what the clinic gets paid, is less because we're seeing fewer patients.
Okay.
Even with the complexity that we see, it still doesn't make up for the fact that we're seeing fewer patients. So, yeah, so we're in a very special little bubble here to be able to offer these services and still accept insurance. Um,
Ah.
However, other offices, if they are seeing 27 patients a day in a conventional practice, they're scheduling 4 patients an hour, then often they'll have cancellations and they can get acute visits in there, and they can schedule some buffers because billing for those 27 patients, they can make it. Does that make sense?
Yes.
Yeah.
Yeah.
So in a functional setting, that's probably a drawback to a functional office, is that we simply cannot afford to schedule blocks of time where the provider isn't seeing anyone in the off chance that there's an acute visit that walks in the door.
All
Yeah.
right. All right. So now, bottom line
Mhm.
is one, you're probably going to have more than one visit,
Yeah.
um, especially if you have multiple things that you want to address. But then
Mhm.
I think the biggest takeaway that I've taken is just ask way more question, provide way more information, then I even in my world, people were like, well, this is TMI. And I'm like, honestly, it wasn't.
Yeah.
Like, that was very helpful for me to know where you're at. And so I think it goes just the same with going
Mhm.
to your primary doctor is like, hey, this actually isn't TMI. It's actually very helpful for me to provide you a better experience overall.
Mhm. Yeah.
So,
Yeah, and just know, I guess the last thing that I wanna say is just know that when we interview you, when you come in for your appointment and we're asking you questions, um, we're doing it in a very methodical way. So I know that there's information that you wanna give to me. Wait till I'm done going through my hierarchy of questions, and then if there's something else that's pertinent, let me know. Um, but yes, there's a method to our madness, I'll say.
yes.
So,
And it's honestly, yeah, it's very helpful to know. And so I really appreciate these last couple episodes because not only did they I learn a lot, but I hope that you guys as listeners learned a lot
mhm,
too. And as always, if you have questions, want some more information on anything, want to even provide feedback on maybe your experiences, we would
mhm,
love to hear from you. And as always, our information is in our show notes, but if you can't find it, our email is askAAPodcast@gmail.com. And then our Instagram handles are mine is Ashley_Olson. That's OLSON_fitness. And then Andrea is Idaho DNP on Instagram. So, yeah, Andrea, this was awesome.
good. I'm so glad that this was helpful. And like Ashley said, please do ply us with questions. I would love to see what questions you have. Would love to hear about your experiences, your frustrations. Maybe I can help to make seeking medical care a little easier on you. So just let us know.
Absolutely. I think, just talking to my people that I work with, the medical industry is so frustrating on our end.
Yeah.
And if we
Hmm.
can just provide a little bit more insight from somebody that's actually in the field to understand where they're sitting and coming from, then maybe our communication barriers will slowly start coming down.
Yes, could not have said that better.
So I hope you guys enjoyed it, and we will catch you on the next episode.
Bye. The content provided in the AA podcast is intended for informational and educational purposes only. The podcast is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The information and opinions expressed in this podcast are solely those of the individuals involved and do not constitute medical advice.